In very simple terms, we've not gone into the medicine yet in that much detail. Just understand that this area of, you see, relative refractory period, which is from 1/3 of final repolarization to restoration of RMP, this this time is very dangerous. You don't want to give a shock around this time. You don't want to you don't even want to get physically hurt on the chest or punched on the chest by this, because there's a condition called commotio cordis or contusio cordis. It's where you might have seen some people who end up in martial art tournaments. They get punched on the chest. This was before people used to wear armor and body armor when they practiced and sparred. If they got punched during this phase, there was a very high chance that their heart would stop working. And it wasn't uncommon to see deaths take place during those competitions in the old days, not like today's martial art tournaments that take place. I'm talking about karate and all those other traditional martial arts. Anyway, the point is, you see these sodium channels over here, and these sodium channels get blocked by your class 1 antiarrhythmics, and they also get blocked by tetrodotoxin. So if you look at tetrodotoxin, again, watch the action potential video of from the neuron. Tetrodotoxin is a poison that you get from the fugu fish, the Japanese puffer fish that are eaten as a delicacy in some Japanese restaurants. Of course, they need a license to make it because it's a very poisonous fish. This poison called tetrodotoxin is actually made by algae that are floating in the ocean, and these fish eat it up, and it gets bioamplified. It gets concentrated in their liver and in their ovaries. In the female fish, it's also in the ovaries. So when a person would unfortunately eat that liver or the ovary in the female fish, then immediately you could see it's affected. The tetrodotoxin will block sodium channels in the neurons and in the heart, causing stoppage of you can't move because your neurons are gone and you won't be able to breathe, and also your heart stops or gets really damaged because you are going to block the sodium channels over there. That's why you have to have a license to make fugu fish. They make this thing called a sashimi, meaning a raw fish, which they take the fugu fish, they cut it into they cut it into thin slices and arrange it in the form of a chrysanthemum flower, and you take pieces of that and dip it in sauce and eat it. Anyway, so you want to be careful with the tetrodotoxin over there. Some people do get injured and get hurt and even die in Japan every year because there is some tetrodotoxin which does accidentally make it into their plate due to some mistakes that take place during the preparation process. Now, giving an antiarrhythmic of the class 1 type does not affect nodal tissue, because if you see SA node, AV node, that action potential is a little different over here. There is no sodium channel over here which gets affected by those drugs. Okay, now, so phase 1 over here is the spike potential we see. It is because of the opening of these channels, the sodium channels, and next after that, so it brings the cell from minus 90 millivolts to plus 35 millivolts. Then those sodium channels close. There's a time dependent closure. So this is very important. The time dependent closure happens within 1 to 2 milliseconds. It gets deactivated very soon. And what happens is potassium currents are there, and potassium leaves the cell. Remember, there's a lot of potassium in the cell. It's around 140 milliequivalents in the cell and only 4 milliequivalents outside the cell. So phase 1 is called early repolarization. It's a partial repolarization. We don't come back all the way to minus 90 resting membrane potential. What happens is there will be an efflux of potassium, and the potassium efflux is going to be so much more important than just the mere inactivation of sodium channels in this phase. And you get this current, which is called transient outward potassium current. This gets activated in phase 1. Transient outward potassium current, and these potassium currents are blocked by 4-aminopyridine. 4-aminopyridine, just be aware of this. Okay, 4-aminopyridine blocks the transient outward potassium currents. Now, what happens is phase 1, if you look at it, it's really prominent and really visible in tissues like your epicardium and mid-myocardial region of the left ventricular wall especially. Okay, so transient outward currents, which are blocked by 4-aminopyridine, play an important role in phase 1 of your cardiac action potential. Okay, in the fast fibers. Then after that, you should be aware that you have the what do we say, phase 2, which is known as plateau. So this is phase 2. If you look at this picture here, this phase 2 is why we have such a long absolute refractory period and a long duration of the action potential, because the heart is in absolute refractory period from here, the beginning of spike potential or phase 0, to 1/3 of phase 3, meaning repolarization. So phase 2, you have the plateau phase. It is non-tetanizable for it makes the heart non-tetanizable and prolongs your action potential up to 300 to 350 milliseconds for your cardiac muscle. Now this how does this plateau happen? Well, ions are moving in and out of the cell, but they move in a way that they're balanced. What happens is you have calcium that enters into the cell. So calcium is entering into the cell, followed by, and at the same time as the calcium is entering into the cell, potassium is leaving the cell. So just imagine this action potential diagram is also like a cell. We use this kind of lingo over here where we draw calcium going in and out in this format. It's just sort of slang. It's understood what it means amongst medical professionals over here, but though it's not official. You want to either perhaps draw something like this diagram. You could see this beautiful diagram that explains the different phases. So look at phase 2, plateau phase. We have calcium influx and potassium efflux, and here I've drawn phase 2 and what's happening. So we have these L-type calcium channels. They're also called late or latent calcium channels. They work slowly. They really open slowly and close slowly. So that's why you're able to get this very prolonged action potential. So calcium keeps entering into the cell, because calcium, again, outside the cell is 5 milli equivalents or 10 milligrams level, but inside the cell it's like nanomoles, nanograms. It's very, very less inside the cytoplasm. So there's a lot of calcium in the blood compared to in the cells over there. And the ionic calcium is like 2.4, 2.5 milli equivalents per liter in its concentration. So calcium likes to come into the cell when these channels open because of the depolarization, and that is balanced by potassium efflux. So potassium efflux is happening because of these ITO currents, transient outward currents, where potassium is leaving the cell. And then you have the delayed rectifier potassium channel. Look at this, I small subscript k is known as delayed rectifier. That's another current over there. And then you have the inward rectifier potassium current, which also gets activated in this phase, mostly towards the end of that phase. Now so calcium comes in and it's balanced by the potassium leaving the cell. That is why there is a plateau phase. There's no change, no visible change over there. Eventually the calcium channels will close, because again it has a time limit for it to stay open, just like those sodium channels had a time limit to stay open over there. So this is going to cause the closure of potassium channels and of calcium channels, and the potassium is still going to keep leaving and exiting the cell. So potassium efflux keeps happening, and that gives rise to phase 3 or potassium efflux. So here we have phase 3. Now you have these in phase 3, complete final depolarization, repolarization takes place, or final repolarization. And this phase 3 is what the ECG picks up for repolarization. Like remember, P, Q, R, S, T. This is the T wave. This is P, this is Q, R, S complex. P is atrial depolarization, Q is ventricular depolarization, T is ventricular repolarization. Now, what is ventricular repolarization? Ventricle is repolarization. So QRS is ventricular depolarization. Now, look at this. If you look at the cardiac muscle, this is what's happening here. You get depolarization phase 0 here for QRS, and phase 3 is what's happening coinciding with T that time. Okay, so this is how it works. You get your action potential this way, and the ECG picks up these different phases. I just spoke about the ventricle. I didn't speak about the atria yet. I'll talk about that later. Look, okay, if you want to talk about atrial depolarization, I'll just draw a better diagram over here, a little bigger one. Here we have, this is the atria, sorry about that, PQRST wave. P is atrial depolarization, and that means the atria is in this stage, phase 0 over here. And repolarization happens to coincide with the QRS complex. So that means atrial repolarization happens during ventricular depolarization. So we can't see that wave because the ventricle is bigger and it's able to make a bigger noise than the atria can. So for that reason, we cannot see a proper dedicated wave for atrial repolarization most of the time. There are rare instances when it can be seen on ECG, but we are not going to discuss about that. As far as you are concerned, you cannot see the atrial repolarization wave because it will coincide with the ventricular depolarization wave, and the ventricles are bigger and they make more sound. Now phase 3 is your final delayed repolarization, where you have the efflux of potassium through those 3 channels we saw, exceeding the calcium influx. The calcium channels close, and you are going to have your transient outward and delayed current or delayed potassium rectifier potassium the current initiating repolarization, and later you get the inward rectifier that comes into play in the later part of this stage of phase 3. Right? And remember, absolute refractory period lasts up to 1/3 of phase 3. You can see over here in red, this is phase 3, and in green I have drawn over here absolute refractory period along this pathway. And phase 3, the red part, is your relative refractory period in this red part over here, this part. Okay, then you have phase 4. Phase 4 is the restoration of RMP. So eventually the potassium efflux causes repolarization to reach minus 90 millivolts, and then you want to restore the ionic concentrations to how they were before the next action potential comes, and that is maintained because of sodium potassium ATPase pump that gets rid of the excess sodium that came in during phase 0. Right? And also we have something called the sodium calcium antiporter. So that takes 3 sodiums in, and it gets rid of a calcium that entered during phase 2. So we had a lot of calcium that entered during phase 2, and also calcium gets released from the L tubules. Remember those dyads, they release a lot of calcium. So the calcium goes down the circa ATPase pump, and some of it also gets pumped outside the cell. This is how you have your action potential.